Ladies and gentlemen, greetings. I am honored to share exciting innovations that will shape the future of neurology. We launched a book on medical cannabis and the effects of cannabinoids on fighting cancer, multiple sclerosis, epilepsy, Parkinson's disease, and other neurodegenerative diseases. Authors contributed chapters from India, Pakistan, Saudi Arabia, Australia, Indonesia, Turkey, and the United States. Keene University Associate Dean Dr. Brian Teasdale joined me in editing the book. He is an expert botanist in medicinal plants, and I am a neuropathologist. The earliest Chinese pharmacopoeia, Divine Farmer's Materia Medica, prescribed cannabis for menstrual cramps, gout, rheumatism, malaria, beriberi, constipation, and absent-mindedness. Based on government records dating back to the Emperor Shen Nung, who developed agriculture in China and Vietnam. You see him here tasting some of the plants because he used to request to test them personally. Cannabis has been used in India to reduce fever, pain, fear, anxiety, epilepsy, chest congestion, nausea, and dysentery for centuries. In 1843, a physician with the British East India Company, Dr. O'Shaughnessy, reported that medicinal cannabis is effective for treating rabies, tetanus, chorea, and convulsions. Assyrian Babylonian cuneiform clay tablets acknowledge the healing benefits of cannabis plants. You see here the cannabis plants. Cannabis is included in the medical papyrus text found in Egypt and in Pliny's earliest Greco-Roman encyclopedia, Naturalis Historiae. Dr. Rita Komalasari discussed the history of cannabis in Indonesia. The Dutch introduced the plant into Amboina, the spice island of the Dutch East Indies. Rumphius cataloged the plants in Amboina. Cannabis was used to treat gonorrhea, pleuritic chest pain, and asthma in the Dutch East Indies. The only significant differences between sativa and indica plants that have been found by genome-wide analysis is in the levels of terpenes. Chemical composition of cannabis extracts depends on temperature, humidity, minerals, carbon dioxide levels before and after harvesting, as well as the length of storage. There are licensing restrictions on the maximum quantities of delta-9 THC that can be sold legally, and it is always combined with CBD. Other cannabinoids can also provide satisfactory therapeutic effects, such as CBG. Phytocannabinoids are produced within glandular trichomes, especially in female plants. CBGs are the precursors for THC and CBD acids, which then get decarboxylated. As you can see, phytocannabinoids have a 21 carbon skeleton with a dibenzopyran ring and a hydrophobic alkyl chain, while endocannabinoids consist of polyunsaturated fatty acid attached to either a glycerol or ethanolamine polar heads. All vertebrates and invertebrates that are higher than insects have endocannabinoid systems. Cannabinoid receptors are distributed all over the body and are believed to facilitate coping with fear, and trauma, and also promoting healing by tissue repair and regeneration. CB1 receptors are prominent in brain cells and may mediate neuroprotection, neuroregeneration, oligodendrocyte survival, and remyelination. CB2 receptors are prominent in immune cells and modulate neuroinflammation. GPR55 receptors modulate procedural memory, motor coordination, anxiety-like behavior, and innate immunity. CB1 receptors are presynaptic in location, and they suppress neurotransmitter release to reduce synaptic activity, and that is referred to as retrograde suppression of central synapses, and that is why you can imagine that they can suppress seizure activity. THC can bind to both the CB1 receptors and the CB2 receptors and is a partial agonist for both. However, CBD has a very low affinity for CB1 and CB2 receptors, and it is believed to act as a negative allosteric modulator for CB1 and either as partial agonist or inverse agonist for CB2. Other cannabinoid receptors include membrane transient receptor potential cation channels, the TRPs, serotonin receptor, and nuclear peroxisome proliferator activated receptors, the PPARs. It is very important to understand that activation of cannabinoid receptors on different cell types may lead to opposing effects. And that is why we need to spend energy and time over the next decades trying to comprehend the endocannabinoid system and how it works, since it has opposing effects that regulate the effects of endocannabinoids and phytocannabinoids. More research is required to further elucidate the complexities of the cannabinoid receptor signaling pathways. These two children in the UK have been receiving cannabis extract to control their intractable seizures for several years. However, the UK government has decided to ban the use of THC whatsoever in children. So now they would have to be switched to using Epidiolex, which is pure CBD, and which we have reviewed the clinical trials showing some satisfactory effect in controlling seizures of intractable seizures. As I said, we systematically reviewed the clinical trials on the efficacy of cannabinoids for control of intractable seizures, focusing on the patients who have developmental epileptic encephalopathies like Dravet syndrome and Lennox-Gastaut syndrome. We found that add-on CBD reduced frequencies of all types of seizures by 30% as compared to placebo. And that 50% of patients experienced a reduction in median seizure frequency by 50% or more. Not many patients became seizure-free, but 5.6% did attain freedom from seizures. And the majority of caregivers reported improvements in overall condition of the patients. We concluded that there was moderate certainty of evidence, primarily deriving from the 4 clinical trials that were placebo-controlled, blinded, and randomized. Evidence that supports the efficacy of add-on CBD for treatment of intractable seizures in Lennox-Gastaut, Dravet, and other DEE syndromes. Research challenges include narrow therapeutic index, low bioavailability from the GI tract, lack of correlations between maximum doses and outcomes between patients and across time, confounding due to the concomitant use of other anti-epileptic drugs, drug-drug interactions that necessitated changes in dosages, placebo effects, and the existence of a subpopulation of non-responders. Approximately 20% of participants withdraw from the studies because they are non-responders for lack of benefit. CBD dosages need to be individually tailored with inter-individual variations, especially in the geriatric population. Proposed CBD anti-seizure molecular mechanisms include neuromodulating effects of G protein-gated calcium channels on CB1 and CB2 receptors, reuptake inhibition of anandamide, one of the endocannabinoids, changing inhibitory and excitatory synaptic activity, targeting the PI3K mTOR signaling pathway, inhibition of adenosine transport, antagonism of GPR55, interaction between CBD and PPAR gamma. Dr. Shahid Bashir from King Fahd Specialist Hospital in Saudi Arabia and co-authors from Pakistan discuss the neurobiology of cannabinoids for multiple sclerosis. CBD decreases T-cell infiltration into the CNS, decreases cytokines, pro-inflammatory cytokines, decreases clinical severity of EAE animal models, and very exciting new development, CBD can mobilize large numbers of myeloid-derived suppressor cells to enter into the CNS and suppress the inflammation ongoing inside the brain. In toxin-induced demyelination models, THC remarkably increases myelin thickness, increases the expression of several myelin proteins, and increases the expression of remyelination markers. This is wonderful. We have never had any medicine that could help multiple sclerosis patients to gain some remyelination activity. This is a revolution, if it is true and if we can use it. The THC can also promote the differentiation of progenitors of oligodendrocytes. These are the oligodendrocyte progenitors that are now able to be induced to differentiate and provide new oligodendrocytes to replace the ones that have died due to the inflammation in MS. We also systematically reviewed the human studies on the efficacy of Sativex, a 1-to-1 CBD THC oral mucosal spray that has been moved to Schedule 4 in the UK since 2013, which means that the UK in 2013 recognized the medical benefits of this medicine made up of equal amounts of CBD and THC, and that it can be moved from Schedule 1 to Schedule 4 and has been used in Europe for many years. And we analyzed its efficacy for relieving spasticity, pain, bladder overactivity, and sleep disturbances in humans. And also we studied all of the animal models. Pain relief was reported at 4 weeks, but seemed to wane over time. Self-reported spasticity scores decreased remarkably in some participants. However, there was a placebo effect seen in the placebo-controlled studies. So here you can see, for example, that there was in some people, they had a very wonderful improvement in their spasticity score by 7.4 points. However, some people, they had a placebo effect, which we then had to subtract. We had to subtract the means from the placebo group and the treatment group, which brought down the overall mean difference following the treatment. There was no improvement in urinary incontinence. However, there were significant improvements in bladder overactivity measures, post-void residual volume, urgency, nocturia, and there was reported improvement in quality of sleep. Challenges include having subpopulations of non-responders, placebo effects, confounding with other MS drugs, narrow therapeutic window, and the subjective nature of the scales for reporting pain, spasticity, quality of sleep, and also the short duration of the studies. When we say that we have done a study on multiple sclerosis patients that went from 1 month to 12 weeks, that is too short in the lifespan of an MS patient, because MS patients, they need something that they can use for many, 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 many years to try and prevent disability, to try and prevent the accrual of neuropathologic damage that will then give them neurological disability. And so we would need to test different compounds and conduct long-term studies on the effects of cannabinoids for MS patients before we can prescribe it. We also systematically reviewed the anti-tumor effects of cannabinoids in brain cancer, lung cancer, breast cancer, prostate cancer, colorectal, and pancreatic cancers. We presented 5 posters at Keen Research Day. There was 1 small human study on glioblastoma multiforme and 2 case reports on lung cancer patients. The rest of the studies were all in experimental models or were done on tissues. This lung tumor shrunk in size from 41 millimeters to 10 millimeters over a period of 2.5 years. The patient was in her 80s and she self-treated with a CBD oil formulation that contained THC and CBD, and she used it 2 to 3 times per day. CBD alone, THC alone, or in combination can inhibit lung cancer cell proliferation, can inhibit TGF-beta-induced epithelial to mesenchymal transition, EMT, EGF-induced migration, and EGFR expression. On the left here, we see a Kaplan-Meier survival curve. And there were 157 patients with non-small cell lung carcinoma, in which improved survival correlated with having higher levels of CB1 and CB2 receptors in the tumors from the lung. A phase 1 clinical trial on 12 glioblastoma patients increased 1-year survival and overall survival. And this improvement correlated with use of add-on nabiximols, which is the same as Sativex, oromucosal spray, up to 30 milligrams CBD and 34 milligrams THC, for a mean of 25 weeks. So the UK has now launched a large-scale clinical trial to evaluate medical cannabis for treatment of brain cancer. CB1 and CB2 expression was higher in astrocytic tumors and astrocytic cell lines as compared to normal astrocytes. Treatment with synthetic cannabinoids decreased cell viability and induced cell shrinkage, membrane blubbing, caspase activation, apoptosis, vacuolization, autophagy, and inhibited mTOR pathway in both wild type and P10 and or TP53 mutants. You see the autophagy here. CB1 receptor expression was higher in well-differentiated colorectal adenocarcinoma as compared to poorly differentiated adenocarcinoma, where the CB1 receptors seem to have been lost. Significant reductions in xenografts tumor volume after CBD treatment were dose-dependent and increased death by trail-induced apoptosis. CBD also inhibited tumor angiogenesis, seen here in breast cancer tumors, and inhibited the AKT angiogenesis signaling pathway. Furthermore, CBD can inhibit cancer cell migration, invasion, and metastasis, seen here in breast cancer. Prostate tumors, including benign prostate hypertrophy, express CB1 and CB2 receptors. As you know, prostate tumors are slow growing, so they don't really lose it completely, even with the high-grade tumors. So, In neoplastic cells, medical cannabis induces cell cycle arrest, induces apoptosis, induces autophagy, so death, cancer cell death by apoptosis and autophagy. It also inhibits adhesion, invasion, migration, and metastasis. In the tumor stroma, it inhibits tumor angiogenesis. A UK drug company has identified a cannabinoid derivative as a candidate new oral cancer treatment. We also reviewed the benefits of cannabinoids in the movement disorder Huntington disease. Add-on synthetic THC improved chorea, dystonia, motor score, neuropsychiatric index, and behavior score in some Huntington disease patients studied in Europe. Dr. Mahesh Patabhiramya and colleagues from India discussed the pros and cons for the use of medical cannabis in Parkinson's disease. Medical cannabis improves resting tremor, bradykinesia, cogwheel rigidity, posture, levodopa-induced dyskinesia, sleep, mood, memory, pain, and fatigue. So it may therefore slow down clinical deterioration in Parkinsonism. However, high THC can impair cognition, memory, concentration, and may even induce episodes of psychosis, especially in some genetically predisposed individuals. Cannabinoids improve motor function in animal models of amyotrophic lateral sclerosis. Dr. Shahid Bashir and colleagues systematically review preclinical studies on the efficacy of cannabinoid treatment in various ALS animal models. Studies evaluate the extent to which treatment with cannabinoids, synthetic and phytocannabinoids, delays disease onset, improves motor function, and increases survival rates in the transgenic ALS animal models. Dr. Ashok Kumar Pandurangan and colleagues from India discussed the potentials of cannabinoid mechanisms to treat motor neuron disease as well, focusing on CB1 receptor-mediated decrease in excitotoxicity due to anti-glutamatergic effects, decreased oxidative stress due to antioxidant effects, or CB2 receptor-mediated reduction in microglial activation due to anti-inflammatory effects. Those would be three possible proposed mechanisms of how cannabinoids can help amyotrophic lateral sclerosis patients, and research is needed to investigate that. Dr. Ashok Kumar Pandurangan and colleagues from India also discuss the link between neurodegeneration and neuroinflammation, providing opportunities for medical cannabis to slow down neurodegeneration by virtue of its anti-inflammatory, neuroprotective, and neuroregenerative properties. Aging or exposure to repetitive brain injury accelerates the formation of extracellular beta amyloid plaques and intracellular neurofibrillary tangles, causing neuronal disruption and loss. The neuropathologic lesions cause astrocytic and microglial activation, thereby triggering neuroinflammation, which then perpetuates further neurodegeneration. Mild cognitive impairment can thus progress to severe dementia. And repetitive traumatic concussive injury can lead very rapidly to chronic traumatic encephalopathy. Bottom panels show the treatment with synthetic cannabinoids. WIN are synthetic cannabinoid, and treatment of animals that were treated with amyloid beta to induce microglial activation, but then when they were also given the cannabinoid agonist, they did not develop microglial activation. So in these rats, treating them with beta amyloid caused the microglial activation, and then adding cannabinoid treatment prevents the induction of microglial activation. So thereby it would prevent the development of neuroinflammation. In fact, cannabinoids have been shown to suppress amyloid beta glutamate excitotoxicity, increase clearance of amyloid beta, reduce amyloid plaques, reduce tau hyperphosphorylation, inhibit acetylcholine esterase, promote neurogenesis, restore memory, and improve cognitive performance in experimental models of dementia and Alzheimer's disease. Dr. Ethan Rousseau, a neurologist and world authority on medicinal cannabis, with Dr. Genevieve Steiner-Lim and colleagues in Australia, cataloged the effects that might slow the progression of Alzheimer's disease. The entourage effect refers to the observed superior therapeutic potency when phytocannabinoids are administered in combination with terpenes and/or flavonoids from the cannabis plant extract. The multitude of mechanisms of action of various cannabinoids, terpenes, and flavonoids may therefore prevent the progression of mild cognitive impairment from becoming moderate and then severe cognitive impairment, which we call Alzheimer's disease. Currently, the purification and testing of cannabinoids has not yet been standardized. So, spectroscopy is the only way to adequately characterize cannabis products. Physicists Sefa Selik and Alev from Istanbul, Turkey, presented the spectroscopic properties of cannabinoids. The QR code can be scanned by the consumers at the store to view the spectral analysis, which is based on vibrational modes and wave numbers of molecular structures. The red line in this graph represents a CBD oil containing 2.75% CBD, while the black line represents a CBD oil containing 5% CBD. This certificate of analysis provides the percent by weight and the concentration of CBDs and THCs detected in one sample tested at Cannabis laboratories. Co-editor Dr. Teasdale and Dr. Sasmita Mishra and colleagues at Keene University discuss the emerging field of cannabidiol plants like liverwort, indigo bush, and rhododendron species. Apparently, secondary metabolites from the cannabidiol plants may be suitable alternative therapeutic agents since they mimic the beneficial effects of phytocannabinoids but cause less adverse effects and less psychoactive effects. Dr. Claudia Knezik and colleagues at Keene University Campus Police, Safety and Forensics discuss the efforts taken at the state level for integration of cannabis law enforcement in New Jersey. Statewide training programs are being implemented to standardize evidence collection, handling of trace evidence, laboratory analysis, and law enforcement practices. I thank Keene University for supporting our research and the development of this book. I am grateful to the St. James School of Medicine for supporting numerous studies from the very beginning. I thank IGI Global Publisher for producing a scientific book to disseminate knowledge about this promising new field and all the contributing authors. Thank you for your attention. I would be happy to take any questions.